Hello, everyone, and welcome. My name's Emma Day. I'm Executive Director of INSU, the International Network on Health and Hepatitis in Substance Users. We are very excited to bring you this webinar today in collaboration with WHO and Médecins du Monde on the WHO Operational Guide for Needle and Syringe Programs for people who inject drugs. Thank you all for taking the time to join us today. We've got a real global audience here, and it's such a pleasure to have you with us. Before we begin, a few quick housekeeping notes. So please feel free to submit questions at any time using the Q&A function at the bottom of your Zoom screen. We'll address as many questions as possible as we go, and we also plan to have some discussion at the end of all the presentations. If you see a question that you really want to see answered, you can bump those up using the thumbs up function. Closed captions are available, so you can access these using the captions button in your Zoom toolbar. We are really pleased to have such a fantastic group of speakers with us today. We're going to have a mix of presentations, obviously on the operational guide itself and the work that's gone into shaping that, but also some country case studies showcasing NSP delivery. So it should be a really fantastic session, and we thank the speaker panel for their time. If there are things that we don't end up addressing or issues that you'd like to see other webinars on, I encourage you to reach out to us. We're always really keen to hear what would be useful. So let's get started. I'd like to hand you over to our moderator who will guide us through today's session, Dr. Nicholas Luhmann, a previous technical officer at WHO and current regional medical advisor for sexual health, HIV, viral hepatitis and STIs at Ile-de-France Regional Health Agency. Nicholas, over to you.
Thanks so much, Emma, and very glad and proud to be here. Thanks a lot for the collaboration with INHSU and Médecins du Monde. I see that there's a very good outcome for this, and I greet everyone to join us. Really, that's one of the last pieces and major pieces I've been involved in at my time in WHO, and I want to as well highlight that this was a collaboration led by Annette Wester, who many of you might know, and as well the main writer of this product is Ernst Wisse, who was a consultant over 9 months with WHO at that time, and he's back at Médecins du Monde. Many of you will know Ernst as well, who's a major leader in the harm reduction public health field. Thanks as well for Antons and Wole to putting together and continuing this work and the publication. And the other thing I want to highlight is actually this operational guide is an update to a document that was published by WHO in 2007, which was the first time that there was a kind of operational guide or implementation guidance published on needle and syringe programs. And we felt that there was quite a lot happening since then, new messages that we wanted to highlight, and Antons will guide us through the new operational guidelines document and content. We wanted to really make it practical, useful, very focused messaging, and highlight everything that has been new in terms of evidence, viral hepatitis, HIV, public health, and other aspects of needle and syringe programs since the first version in 2007. And we hope that is achieved, and we will see now from Anton's at the presentations of the tool what are the main messages. Important as well to highlight that this is endorsed and co-labeled by UNODC and UNAIDS, which I think is very important. And I want to say as well that this is a guidance document that has been kind of developed in the framework, or as well at least supported through the framework of the WHO collaboration with UNITAID within the Hep C prevention grant, and supported by UNITAID to that effect. So now let's start. That was long enough. I hand over to the director of the WHO Department for HIV, Tuberculosis, Hepatitis, and Sexually Transmitted Infection. And we are very proud, as you may imagine, that Teresa Kazeva is joining us to launch this webinar before Anton's presentation of the tool. Thanks, Teresa, for joining. It's EB, and so we appreciate it really.
Thank you very much, Nicholas, Emma, for excellent introduction. Good morning, good afternoon, and good evening to everyone joining us today. Thank you for joining this important webinar from across the world, and it's my pleasure to welcome you to this WHO webinar to launch an important new WHO resource, updated resource, the Operational Guide on Needle and Syringe Programs for People who Inject Drugs. People who inject drugs continue, as we know, to face some of the highest risks of HIV, viral hepatitis, overdose, and other preventable harms. We know this. The evidence has been clear for decades. And yet, in many countries, access to effective needle and syringe programs remains far from adequate. Services are often too limited, too vertical, too restricted, and shaped by neglect and stigma rather than by public health need. This new operational guide is designed to change that. We hope so through practical guidance for effective programs that are tailored to local contexts and integrated into national health and harm reduction frameworks to be used by countries, programs, managers, implementers, and communities. I look forward to having some very interesting discussion during this webinar, as we have a great lineup of speakers, but I would like to reinforce a few key messages. First, needle and syringe programs are essential public health interventions. We have to put spotlight on these and remind to ourselves and to everyone. They prevent HIV and hepatitis C. They reduce injection-related infections. They help prevent overdose, and they often provide the first and sometimes only point of contact with health services. Second, access must be more than availability. Programs must ensure enough sterile equipment for every injection, flexible service models, and care that is respectful and not non-judgmental. Third, and critical, the guide places communities at the center. People who inject drugs are not just service users. They are leaders, peer workers, and experts in what works. Community-led approaches are fundamental to trust, reach, and impact. And finally, the guide is clear that stigma, discrimination, and criminalization continue to undermine health outcomes. Addressing these barriers is not optional. It is essential for equity and effectiveness. This guide reflects the collective work, as Nicholas highlighted already, of WHO, UNAIDS, UNODC, UNITAID, technical partners, donors, and people with lived experience from around the world. It is grounded in evidence, shaped by practice, and guided by human rights. We hope it will help countries strengthen and expand needles and syringe programs and accelerate progress towards our shared 2030 goals. Thank you once again for your great commitment, for your dedication and hard work, and I look forward to our fruitful discussion today and its outcomes. Thank you.
Thanks so much, Teresa. That's a really very, very clear and important and spot-on messages. I think is extremely well summarized, some of the highlights, and I thank you for joining and speaking so clearly and focusing as well that this is all evidence-based material and guidance. So before I hand over to Antons, I just wanted to say again, because some people might have joined a little bit late, that there is a Q&A and that people, the panelists are very happy to answer your questions and that we will hopefully have a discussion session at the end. Thanks again, Teresa, and I'll hand over to Antons, who will go into more detail with presenting the new operational guidance. Anton is a medical doctor and he's technical officer for key populations at the WHO Global HIV, Tuberculosis, Hepatitis, and STI program. He has been as well in the regional office of the Euro region before, and he is an expert in public health, surveillance, and community-focused response. And he will present the main content of the new guidance. Thanks, Antons, for joining and making all this happening.
Thank you very much, Niklas and Teresa, for joining and providing the opening remarks. And maybe just a little notes about the logistics. For those who joined later, there's also a possibility to see the translated captions, do almost any language. So for those who are not native English speakers and prefer to get, you can try this option as well. So let me share my screen. Okay, anyways, so it's a pleasure to introduce this new WHO, this new WHO document, the operational guide on needle and syringe programs for people who inject drugs. So this guide was developed to support countries and partners to implement and scale up effective needle and syringe programs. I will highlight the key messages and the structure of this new resource. So maybe just for the beginning, what is harm reduction and what is the WHO position? Harm reduction is a public health and human rights-based approach to reduce social and health harms of drug use, importantly, without necessarily requiring abstinence. The core element, as per WHO guidance, is the needle syringe programs, opioid agonist maintenance treatment, naloxone, hepatitis and HIV services, stigma reduction, and enabling legal environment. It matters because people who inject drugs face disproportionately high burdens of HIV, hepatitis C, and also overdose. Harm reduction is highly cost-effective. It reduces mortality and essential for achieving global HIV and hepatitis targets. So WHO position is clear. It's evidence-based, essential service, and it should be fully integrated into national health systems with community leadership as a core component. So for the context, we know that there are globally about 14 to 15 million people who inject drugs. We also know that the needle and syringe programs are proven to work.
Sorry. Are you trying to show your slides, or are you just talking before you share? Because we can't see any.
Oh, right. Good point. I'm showing my slide, but I don't know why you don't see them.
Send it to me.
Can you see now?
Now we can. Yeah.
Great.
It's presentation mode. Thanks.
Excellent. So yes, as I mentioned, for the context, it's proven that needle and syringe programs are effective, and they can reduce the acquisition of hepatitis C by half and HIV by 76% when coverage is sufficiently high. And despite the decades of evidence, only 50 countries have any NSP programs, and very few meet the recommended coverage levels. So WHO, as I already mentioned, has a clear position that NSP are essential public health interventions, and they are first point of contact with marginalized people who inject drugs. They are not only critical for prevention of blood-borne infections, but they also strengthen links to HIV, hepatitis C, and tuberculosis services, and are also relatively cheap and easy to implement. WHO has a number of graded recommendations on needle and syringe programs already since 2016. It's a strong recommendation that all individuals from key populations who inject drugs should have access to sterile injection equipment through the needle and syringe programs. There are also a number of good practice statements that include recommendations on the community-led services, on enabling interventions, and so on. You can find them in the WHO consolidated guidelines for key populations. So what is new in this guide? Previous WHO guidance explained what countries should do, and this guide focuses on how to do it. It translates global recommendations into step-by-step operational guidance, practical tools and templates, and real program examples. It is designed for program managers, for service providers, community organizations, and also for donors. So going to the structure of the guide, it has 5 modules which kind of guide us through establishing and developing and running the NSP programs. So the first modules is about assessment and planning, and it includes 3 steps. The step 1 is about size estimation. We know that reliable population size estimates are important, but it's also important to understand that services should start even without perfect data. And also implementation often generates the better data over time. Community-centered approaches are simple, low cost, and repeatable, also to generating size estimations. Second step is values and preferences, and meaningful community involvement is the foundation of effective harm reduction. Assessing values and preferences ensures that programs respond to real needs and increase uptake and effectiveness. The third step on quantification and planning, and there is very important clarification which we emphasize in this guide, that the global health sector strategy of 300 syringes per person are its population level indicator and is not meant for program planning. So in practice, programs often require or people who inject require, for example, 3 syringes per person per day, and that would translate into 1,000 syringes per person per year in the program. There will be a presentation from partners who will present this quantification tool more in detail. The second module is about service delivery model or implementation models. So there is no single model that fits all settings. Services must reflect local context, drug use pattern, and available resources. A combination of model often maximizes the impact. Outreach programs, mobile services, fixed sites, secondary distribution, also syringe vending machines, online and postal services, pharmacies, and other alternative distribution models. Community involvement is essential for trust and access. Module 3 speaks about the comprehensive services. As already mentioned several times, needle and syringe programs are often the gateway to care. They provide entry to health services for marginalized groups, linked to HIV, TB, and hepatitis testing and treatment, and support retention and re-engagement in care. Without NSP, many people would remain excluded from health services. Module number 4 speaks about monitoring that should be purposeful and proportionate. Key principles include collecting only necessary data, protecting anonymity and confidentiality, and prioritizing service delivery if data collection becomes a barrier. Community-led monitoring strengthens accountability and quality. Finally, the last module is about scaling up and ensuring sustainability. Many needle and syringe programs start as pilot projects, often funded by donors, but pilots alone are not enough for public health impact. Scale-up requires broad coverage, strong political commitment, sustainable funding, advocacy, and community leadership. And people with lived experience are powerful advocates for change. This guide is grounded in 8 guiding principles. NSP are essential public health interventions. They are human rights based, focused on equitable access and coverage, community-centered, are applicable in all contexts and adaptable to changing drug markets. They're part of comprehensive harm reduction services and must address stigma and discrimination. This principle underpins the entire guide. I welcome you to download this guideline. I think we'll share the link in the chat or in the Q&A. And I would like to thank, first of all, the people who led the development of this guideline. That's Ernst Wisse, who was a consultant and currently works with Médecins du Monde, which is a strong partner in the work for WHO, especially in the world of harm reduction. Niklas Luhmann, who is moderating this webinar, and Annette Verster, whom you already know. The core working group and all the reviewers who provided inputs to the guide, and the Unitate for funding this work. And thank you for your attention, and I look forward for the discussion at the end of the webinar. Over.
Thanks so much, Antons, for presenting this so clearly and highlighting. I think one of the key aspects here is that we've really tried to be very thoughtful about being practical, focused in the messaging, and comprehensive. And I hope that people can look in more detail at the guide and its language and its messages. Thanks a lot for staying on time and making this so clear, Antons. We will move on to someone who will be known as well to many, many people, which is Annie Madden from Australia, where it is late already. But and I'm very happy to welcome her to be the next speaker. She's a project lead at the Input International Network of People Who Use Drugs. I think she's very well known in Australia, but as well international for advocacy and research work. And I think she will present on what will be called values and preferences work. That is something that has really partially emerged through the Unitate collaboration in the way, and I hope she can highlight how important it is to really consider, preferences in terms of products of users, so that we can meet the needs of users and clients in the different contexts. And I hand over to Annie, hope her connection is well, and I welcome her very warmly.
Thanks, Nicholas. I'm hoping everyone can hear me and see my slides. All right. Yeah, that's okay. Okay. Thank you for that warm welcome, and good evening, good morning, good afternoon, wherever you are, everyone. As said, my name is Annie Madden. I'm from the International Network of People Who Use Drugs, known to many as Input. And probably also to say, because I always try to do this, is that because my comments, my work, my presentations are very much informed by my own living experience. I am a person who injects drugs. I have been the beneficiary and had access to and used needle and syringe programs for many decades in many parts of the world. And those kinds of experiences inform what I'm going to talk to you about and my contributions to the space. So I thank you very much for the time to do that. So at the recent INHSU conference in Cape Town, in fact, I actually presented, I was asked to present on community-led values and preferences in relation to needle and syringe programs. And I'm sure there are people here who are at that session and that conference. I apologize for that, but I am going to start with reiterating a few things I said just to begin in that presentation, because I think they frame up the need for and the importance of values and preferences for needle and syringe program procurement and service planning very, very well. So what I said was that for decades, we've known that needle and syringe programs save lives. They reduce HIV and hepatitis C transmissions and other injecting related harms such as overdose and soft tissue and systemic infections. they connect people to care, and they strengthen communities. And we've heard those comments by others already. The evidence is really strong, and it's also unequivocal. Yet, despite all the evidence of the life-saving benefits of NSP, we still have too few programs. And where they do exist, too many programs still fall short. So supplies run out, budgets are often inadequate to meet demand and coverage, the wrong or poor equipment or poorly adapted supplies are procured, sometimes repeatedly. And while, of course, there are many good services, there are also services where people feel unsafe or simply unwelcome. So the question really isn't what works. We know what works. The question is more about whose voices and needs are guiding what we do. And that is where community-led values and preferences come in. So community values and preferences drive NSP success. It's as simple as that. And that's because meaningful community involvement is not just about, you know, an additional extra or a nice to have if you can kind of manage it. Community involvement is actually the very foundation of effective harm reduction. Why? Because NSPs work best when they're shaped by the lived realities of people who inject drugs, because consulting communities early on their values and preferences in relation to their injecting equipment preferences, their service needs, barriers and facilitators to access, these things build trust, but they also build services that are relevant for people's real lives. It's also because, you know, and not surprisingly really, when people see their voices reflected in services that are meant for them, they're more likely to trust those services and, importantly, are more likely to use those services. Often, though, I find myself in conversations with, you know, what I'd say are well-meaning service providers in the conversation about values and preferences. But people will say things like, well, you know, we'd really love to do sort of values and preferences to inform our NSP procurement and our service delivery models, etc. But it's just too hard because we don't have an established formal community-led network. And I guess the reality is, and what I tend to talk about with those people, is that there is an increasing amount of really good specialist technical assistance available to people who find themselves in the position of running and providing service NSP services, but perhaps are not sure where to start with values and preferences and want to do that. So there's input, the international network at the global level, always prepared to provide specialist technical assistance to, particularly on issues around NSP. There's regional networks of people who use drugs. We now have regional networks in most of the major regions of the world. And there's also many country-based networks of people who use drugs. And, you know, it could be that maybe you don't have a country-based network in your country, but there might be one in a country close by. And you might be able to reach out and get technical assistance from them to assist you in getting started in this space. There's also groups and organisations like COACT, whose business is to provide this kind of specialist technical assistance. So there are many ways that people can get the kind of support they need to get involved in values and preferences and use that as a basis for decision making. But it's really important to also sort of add, I think, that I've seen many times that if, you know, you don't have an established network in your country or your area at the moment, values and preferences can be and has been a really important catalyst actually for emerging networks and a way to really strengthen any fledgling groups or networks that might be there. So it also has that other really important aspect to it. So community values and preferences then is a critical step in getting NSP procurement right to ensure best use of available resources, and that's especially important in resource limited settings, and it can lead to many other positive outcomes associated with empowering the community. But there's one thing that values and preferences is not. Values and preferences is not rocket science, as they say. You don't need lots of resources. You don't need a well-funded research grant to get started. There's not just one way to do it properly. There are many, many ways to engage with community, with your NSP beneficiaries. It's about getting started, and it's about engaging meaningfully, listening carefully, and importantly, listening continuously. So not just asking once, but starting what will become an ongoing conversation with service users, with NSP beneficiaries. And it's also very importantly about having a commitment to acting in a transparent manner on what you learn when you do consult with community. That doesn't mean to say that you need to do everything that is said, but it is about having a real transparent conversation and respectful conversation about what is possible and how that needs to be done. So just to finish, I just want to sort of zoom in on the operational guide. I have to say, as a member of the core working group, it was an absolute privilege to be part of revising and developing this resource. I think it's incredibly important for our community. If you're looking for the specific content on values and preferences, so as I've pointed out there, page 13 really gets into and spells out some of the key points around why community values and preferences is important for NSP procurement. And then there's also Annex 2, which is toward the back of the resource, which is a really practical tool for establishing values and preferences of people who inject drugs, for procurement of injecting supplies. It's got a really great practical 5-step process that is really accessible even for those doing this for the first time, especially for those people actually, and also tips on making consultation with beneficiaries meaningful and respectful. So I really commend that to you. I want to really acknowledge the work of everyone involved, and Ernst as the consultant, but also my colleagues and peers on the core working group who gave amazing technical knowledge and expertise to make this resource what it has become. And to finally just say, this is really an important step forward in Input's perspective in making community values and preferences a really integral part of what we consider is a best practice approach to NSP procurement and to wider service planning in general for services for people who inject drugs. And we're really very glad to see it and be part of its production. So thank you very much for your time.
Thanks so much, Annie, for highlighting this extremely important aspect. I think in some way, this is not just some nice to have or add on. In fact, in my experience, it happened very regularly. You go to a country or a program and people start to tell you that the material that they're receiving is not the thing that they would like to use or that they're actually using. So I think this is a very important aspect in terms of the response and in terms of engagement, as you said so beautifully. So this was one example for why this guide is actually very practical. And as you said, it has an annex and it has the language as well in the main part of the document that drives people through or guides people through using this approach and making it happening in the field. Now, the next speaker will give us another example for something very practical, which is included in this guide and that hasn't been included before, which is a quantification tool for needle and syringe programs. So I'm very happy to welcome Kanish Gupta, who has worked, I believe, with Ernst and all of us on making this happening and including it in the guide. Kanish is a market shaping officer at PATH, which you all know is an international NGO who's accelerating global public health innovations and advances health equity in many program areas, not only in, let's say, harm reduction, but they are more and more working in this area as well. And we're looking forward to your presentation, Kanishk. I hope your connection is good and we can see you. Thanks for joining us.
Thank you, Nicholas. I hope my slides are visible. If not, please signal.
Yes, they are.
Okay, thank you. Hello, everyone. Thank you very much for joining this webinar to launch the new WHO technical document. My name is Kanishk Gupta. I'm working as a market shaping officer with PATH. In the next 10 minutes, I'll walk you through the quantification and practical planning considerations that underpin an effective needles and syringe program. Understand how better quantification supports safer injecting and better health outcomes. And lastly, I will also talk about an NSP quantification tool that PATH developed in partnership with the WHO, following the recommendations of an international working group from 2024. So WHO guidance is very clear. People who inject drugs should have reliable access to sterile injecting equipment, but in practice, many programs fall short. Often this is not due to lack of intention, but it's due to weak quantification, limited understanding of community preferences, restrictive distribution policies, inadequate funding, or restrictive regulations. When supply doesn't match the real demand, people are pushed towards reuse and sharing, which undercuts progress towards HIV and hepatitis C elimination. And this is why a robust quantification is so central to an effective NSP. As I mentioned, in 2024, an international working group was convened to examine the barriers and recommend strategies for more effective NSPs in low and middle income countries. Across LMICs, similar challenges were observed: insufficient volumes being requested, procurement processes that do not prioritize community preferred products, stockouts that force rationing. To add to that, a common misconception of the 300 needles and syringes per person per year. So the GHSS, as part of GHSS, WHO set a population level average of 300 needles and syringes per person by 2030 to achieve elimination targets. However, this has not been followed very well. In fact, the idea is that people who inject drugs should have as much access to sterile injecting equipment as needed. Yet many programs adopt this as a programmatic cap at an individual level rather than understanding it in the true sense. Now, to address these barriers, the group recommended developing a robust quantification, preferences-driven quantification tool, and integrating this into national planning and global fund applications. The NSP quantification shouldn't be seen as a mere calculation. In fact, an effective NSP quantification is a core strategy that is evidence-driven, considers values and preferences of the community, influences procurement decisions, service coverage targets, and ultimately the health outcomes. I'm so sorry. So to respond to these needs, PATH in collaboration with WHO has developed a practical NSP quantification tool. This is an initial or a beta version that offers an initial but structured way to integrate population size estimates, values and preferences research, and service coverage goals into realistic demand planning. The idea is to make quantifications more and more aligned with what the community really needs and prefers, and at the same time, motivate the programs to provide better choice. The current version focuses on usability, through a simple interface, easy to start and finish the process, and an interactive flow. That being said, future versions will expand this to include other modules that can span across budgeting and supply planning models as well. Once the tool is downloaded from the link provided, and you can also find the same in the published WHO technical document as well. The first step is to enable editing and enabling macros as the tool is opened up. This unlocks automated calculations and workflows. Some users, depending on their institutional security requirements, may also need to trust source as it is downloaded through a third-party link. We have structured this tool so that users can follow a clear step-by-step process, which is designed for program implementers who may not even have a prior experience or at quantification or at using formal tools to that regard. Now, throughout the process, the prompts provide you guidance on what information needs to be entered and how the adjustments can be made depending on the local context. A robust quantification starts with two major pieces of information: population estimates and values and preferences research. These offer a realistic basis for establishing annual coverage and understanding what products people actually use. Values and preferences research are especially the best starting point as they help to understand drug use patterns, injecting frequencies, and types of equipment needed, which are all required for good quantifications. But that being said, we also understand that a good data isn't always available, and these research may not have happened in many countries and contexts. So initiating services always often helps to generate better data over a period of time. So programs shouldn't wait for perfect data to get started, but they should get started by using other means. For example, programmatic knowledge. For example, consulting other learnings from other countries, and engaging with community members for initial planning and kickoffs. The tool brings several helpful features together to reduce manual work and errors in calculations. Different user profiles have different preferences. Often users require separate equipment for preparation and injection. The tool covers equipment beyond needles and syringes, including preparation items. And most importantly, it calculates it takes a need-based calculation approach on actual injecting practices rather than applying a cap of like 300 needles and syringes per person per year. Moreover, design features like color-coded cells, automatic calculations, default frequencies, and manual overrides allow users for both standardization and customization to their local context. As this has been the first time such a tool has been introduced, we have been very deliberate on focusing on usability to keep it extremely simple, easy to use, easy to begin, and easy to finish, and keep it interactive. Moreover, a focus has been on needles and syringes, 1 year planning horizon, and maximum number of profile and products in the current version. These constraints helped to keep the tool lightweight and super easy to use. For future versions, we are actively exploring features like multi-year forecasting, integrated cost estimates, budgeting, supply planning modules, visual dashboards. Our goal is to refine the tool based on real-world feedback from implementers. To wrap up, the tool is freely available through the WHO website, and it is part of the tool. You can just click on the link provided in the guidance, and it will take you to where you can download it. We encourage programs and implementers to download it, test it, and share feedback with us. This collaboration between PATH, WHO, and United aims to ensure that quantification becomes a facilitator and not a barrier to delivering a very effective needle and syringe program. Please feel free to reach out to me or my colleague Viviana with any questions on for support in integrating this tool into your planning. Thank you very much for your time.
Thanks so much, Kanishk. Excellent presentation and excellent tool, excellent work. The next two presentations are really on country examples. I think the organizers imagined to have two examples, one from a high-income country with a really high scale of needle and syringe programs, which is Australia, and then Myanmar for a more low and middle-income country context. So Lisa Maher from Australia will present the Australia example. Thanks, Lisa. Over to you. I'm sorry if that dropped.
Thanks, Nicholas. Okay. Sorry.
Okay, connection as well. I can see you, and now I think you're bringing up the presentation. Okay, yeah, we can see it. Please go ahead.
Yeah, trying to get it from the beginning. Okay, thanks everyone. They've been great presentations so far. Before I talk about Australia, I'd just like to say that we've actually been using this guide in Fiji, where we're working with the government to introduce NSP as part of the response to a major outbreak of HIV among people who inject drugs. And we've also had the benefit of having Ernst out in Suva to convene an implementation workshop. So it's already been an incredibly useful tool, in a kind of complex and a very challenging setting. But I'm going to talk about Australia now. And I guess how Australia contained HIV among people who inject drugs. So we have in this country one of the lowest HIV prevalences among people who inject drugs in the world. So it's consistently been less than 2%. And this is strongly linked to the early adoption and large-scale coverage of needle and syringe programs. And I guess I'm trying to get rid of all this stuff on my screen. People who inject drugs were central actors rather than passive recipients in preventing the HIV epidemic, and success was a result of people working together, investing early, scaling up, and sticking with harm reduction, despite, I guess, bipartisan political support at the beginning, but lots of incidents and issues and stuff. But the government pretty much has stuck with harm reduction. So just a bit of a timeline. When HIV first emerged, there was fears, as elsewhere, that there'd be explosive spread through injection drug use. And in 1984, 1985, we had federal leadership under the then Health Minister, Neil Blewett, which was responding to different experiences overseas by funding prevention before the epidemic actually got underway in Australia. So harm reduction was adopted as the official national drug policy very early on in April 1985. And that provided political cover for later NSP expansion. In 1986-87, the first NSPs were set up, including civil disobedience pilot NSPs by health workers and people who use drugs advocates in New South Wales. And governments chose not to prosecute, but rather to scale up NSP services. And by late 1988, which is not very much time, within 3 years, we had a national network of needle and syringe programs operating across all states and territories in Australia. So it's very much a partnership model with lots of leadership from drug user organisations, which by 1990, peer-driven drug user organisations were operational in every state and territory, and they were supporting NSP reach and acceptability, and later went on to run their own NSPs. We had support from governments, as I've just said, but not just the federal government, but jurisdictional, so state and territory governments, clinicians and researchers. As I've said, the rollout of NSP was supported by bipartisan political commitments. So across the two major political parties, or three, including the coalition. NSPs continue to be explicitly recognised in our national bloodborne virus and STI strategies as a key prevention tool. And I think one of the things that Australia has also done quite well is to prioritise HIV prevention over moral debates about drug use. These kind of things changed with hepatitis C, but we're focusing on HIV tonight. So what does high coverage NSP look like? In Australia, we have over 4,500 NSP sites spread throughout the country. We have multiple modes of delivery. We have primary NSPs, secondary outlets, vending machines. We have supply through mail order, which really came into its own during COVID. We have pharmacy programs, and these are subsidised by the government, and we have peer distribution programs. We have NSP in remote and rural areas. There's some, we'll just look at, by remoteness area nationally, you can see here that, pharmacies do a lot of the heavy lifting in remote areas. But also we have some secondary, which are mainly hospital casualty departments, and they do a lot of the heavy lifting in those very remote communities. And on the other side, we have NSP outlet by capital city. And you can see that pharmacies and primaries are focused in the capital cities and not so much in the rest of the state. So the split between public and pharmacy sector, the public sector NSPs in Australia distribute the overwhelming majority of needles and syringes. And you can see that in the last year, so say 2024-25, for which we have data available, these services combined pharmacy and the range of public programs distributed 64.4 million needles and syringes, as well as a whole lot of other injecting equipment, which we also measure. Just looking briefly at coverage. So national syringe coverage per person who injects drugs per year from 2015, when we first started measuring this, to the most recent year, which is 2024-25. So this is based on a 2024-25 population size estimate of 72,441 people who inject drugs, which equals about 889 needles and syringes per person per annum, which exceeds the UNAIDS definition of high syringe coverage by more than fourfold. And coverages like syringe coverage per injection remained high at 136% in 2024-25. We've also got very good surveillance systems in place, or we have had historically, and hopefully that will be ongoing. But the government, particularly the federal government, recognised early and invested in surveillance and evaluation in order to have this data to use to maintain community and bipartisan political support. We have the Australian Needle and Syringe Program Survey, which is a biobehavioural sentinel surveillance system that's been going for 31 years now and recruits about 2,000 NSP clients from about 50 NSPs nationally. Those participants provide a brief anonymous questionnaire and provide a capillary blood sample, which we test for HIV and hepatitis C antibody and RNA. This data source enables us to monitor kind of short and long-term trends, but also to track who the people are, not identify them, but to track them anonymously over time to make a kind of virtual cohort. The NSP National Minimum Data Collection is a programmatic data set, which only commenced about 10 years ago, and it includes data from all jurisdictions on NSP provision, and it includes individual levels, occasions of service data, client demographic characteristics, drugs injected, and the provision of health education interventions and referrals data. And we use these data combined with the ANSPS to annually update our population size estimates and both per capita and per person who injects drugs, needle and syringe coverage estimates. We've done a little bit of work around return on investment, and that also has been very politically important in kind of sustaining, I guess, government interest, but also, not having, community backlash around, what have I done? NSPs, from current slide. So we've done these cost benefit analyses. The first one was very complex mathematical modeling. We have more recently developed a less onerous mechanism to be able to look at the kind of return on investment that both data sets, the return on investment, the study in 2012 found that for every dollar spent on needle and syringe programs, it would have a return of $4.26 in averted healthcare costs. And this should not have the between there. In 2024, each dollar spent on NSPs, we estimated, would have a return of $5.82 in averted healthcare costs in Australia. And when we include injection-related injuries and disease in that, the return actually increases to $6.17. But the data are a bit, they're not the data we'd like to have available to use as estimates. So I think we're going to publish that without the ERA data in there.
Lisa, can you finish in about 1 minute, please?
Challenges, so priority populations among people who inject drugs. So particularly responding to the risks and service provisions needs of First Nations, Australians, and people in remote and rural communities, particularly remote communities, and people in closed settings. We still have no NSP in closed settings in Australia, but we do have a high incidence of primary and hepatitis C reinfection. And that's it. I'd just like to thank, particularly my colleague Sue Hurd and the Commonwealth Government of Australia for continuing to fund these projects, and everyone else on this list of acknowledgements. Thank you.
Thanks so much for this country example. We're moving now, which is very interesting as well, with the return on investment, for example, and your high coverage. Australia is really very important in this program area and other areas of public health. We move to Myanmar. I hope that Ted So is online and that his connection is good enough to show us some updates from Myanmar. I don't know if we will have time for a long discussion at the end. I invite you to look at the Q&A. Anton, Swole, Ernst, many are giving very good answers there, and you find all the links to the tools and the guidance there. Please look at the Q&A. So we will hear from Ted So, who is working for Médecins du Monde in Myanmar on harm reduction.
Thank you, Nicholas. So let me share screen. Share the screen. So.
Okay, we can see. You can go ahead, please.
Okay. So good mornings and good afternoons, ladies and gentlemen. So greeting from Myanmar. So please allow me to present the practical implementation about the needle and syringe programs of Myanmar in Kachin by the Medecins du Monde. So in Kachin state is the northern parts of Myanmar. So it has faced the extent the conflict and political instability that creating an enabling environments for the drug production, trafficking, and widespread of drug use. So in Kachin, so in heroines and opiates has been used for decades. So particularly among adult, young men, migrant workers in jade and gold mining areas. So in recent years, amphetamine-type stimulant drug use has increased of an estimated 40,000 of people who use 5,000 of people who inject heroin, that placing them at the high risk of HIV, hepatitis B disease, and overdose. The high drug availability has led to early initiation and drug use, and HIV prevalence among people who inject drug is estimated and approximately 33.8 according to the latest IBBS of Myanmar, and around 180 overall cases reported annually. So ongoing conflicts had displaced communities and reduced access to health services, and particularly in insufficient space for needed and stream programs and treatment services. So for an effective needed and stream program, the having the reliable site estimation are critical. So to support evidence-based planning, so that's why MDN carry out this population site assessment in 3 townships, that's Mogal, Monians, and Hopins. And we identify and around are being reached the services. And also the key for improvement and engagement is the core or the NSP model in MDN. So MDN was with 140 trained PS workers and who serve between people who use drug and the harm reduction programs. And their close connection with the communities enables effective delivery of services. And their safety is also prioritized through the provisions of ID cards, mission orders, and protective equipment. And MDI is applied the community-led micro-planning approach, which is decentralized outreach management to PS workers within their own community. So this approach allows the PS worker to decide how to reach clients and delivers harm reduction services based on the local context and individual needs. On average, each PS worker is engaged approximately 100 people who use drugs. So in MDN, needed and syringe distribution is implemented through 4 complementary channels: outreach, drop-in centers, and mobile units and secondary distributions. So the program is primarily relies on direct face-to-face engagement by the PS workers to ensure consistent access to injecting equipment. So across the channel, MDN distribute approximately 5.4 million NS annually. So outreach program is a key approach led by the PS workers and supported community worker members. So the thing goes directly to hotspots, injecting sites, and gathering places of people who use drugs by foot and sometimes by motorbikes. So this approach, so we reach clients who may not access DNC-based services. So during outreach, the PS workers distribute needed and syringe, provide health education, identifying clients whose additional support, and we provide the accompanying referrals to the drop-in centers. And PS workers also collect use needed and syringe during the outreach activities. For the drop-in centers, so we provide a safe space for people who use drugs, and we offer comprehensive facility-based services, including health education and needed and syringe, condom, IC distribution, testing and counseling, and social support. It serves both referring clients and those referred from the outreach programs. In close collaboration with the outreach programs and the Modigat team, so we organize the mobile plans by occur, which is focusing on the hard-to-reach areas. In mobile unit, we offer comprehensive harm reduction services to ensure access for the individual who cannot visit and come to the drop-in centers. And we also train Sahab groups and key stakeholders and drug dealers as a secondary distributors. Then we provide with the appropriate supplies or needed and syringe and including naloxones. PS workers and community workers members are closely monitoring to them. So this secondary distribution model is fully integrated with outreach programs, drop-in centers, and mobile units, and expanding the harm reduction services across the coverage areas. So this is the trend in HIV incidents following scale for harm reduction interventions, the among people who inject drugs in Gachin, Myanmar, and analyzes a retrospective cohort data set of 2008 to 2020 by the Peters of the Bristol University. So then MDN launched this program in 2023, so we observed a strong finding when the highest numbers of needle and syringe are distributed. The incidence case decreased among the people who use drug. So as a conclusion, so I would like to highlight and drop some of the key messages here. So drug use in Kachin is not very new issue. The recent political economic crisis had further intensified existing vulnerabilities. Addressing drug use in Kachin requires combination approach to maximize the impact, that including the conflict-sensitive harm reduction approach and community-based NSP services with the sufficient human resources, and protections and support for the peers workers and long-term and integrate the public health responses. So to achieve meaningful the impacts, very high needle and syringe availability requires more than 500 needle and syringe per person in a year. So thank you for your attention. So it's over to you, Nicholas. Thank you.
Amazing to hear from you, Tetsuo, from this very interesting country and context. It is really very different to many other contexts. It's quite rural in Kachin up there. And so the work that you and all the team is doing is really amazing. Thanks for sharing that as an example. It's really inspiring, and shows as well how much you have to adapt in some way, like the Australia example, use different operational models and adapt to a changing environment all the time. So I think our last speaker now will be Ehab Salah. He is from the UNODC office in Vienna and is the advisor on prison and HIV. And he will talk to NSP in prison and other closed settings, which is another complex issue. I don't know, Ehab, your video was not working at the technical when we tried to prepare the webinar this morning, but anyway, you will speak without slides, and please keep on time. We only have 6-7 minutes left in this webinar.
Thank you very much, Nicholas. Can you see me?
Oh, we can see you.
Perfect. Great. Thank you very much. And good morning and good afternoon, everyone. First, I would like to thank WHO for organizing this webinar and for the opportunity to speak today. It's a privilege to be part of this event and to contribute to such an important discussion. Injecting drug use has long been linked to a range of serious yet preventable health risks, including overdose and the transmission of bloodborne infections such as HIV and viral hepatitis. Harm reduction interventions are proven evidence-based responses to the health challenges associated with injecting drug use. Needle and syringe program has consistently been shown to significantly reduce HIV and viral hepatitis transmission while improving overall health outcomes, especially among highly vulnerable populations, including people in prison settings. An estimated 11.7 million people are incarcerated worldwide at any given time. People in prisons are frequently underserved by national healthcare systems, often face limited access to timely, comprehensive, and continuous care compared with the general populations. International standards, including the Nelson Mandela Rules, affirms that incarcerated individuals are entitled to the same standard of health care available in the community, free of charge and without discrimination. This obligation extends to evidence-based harm reduction services, including needle and syringe programs. Structural barriers, stigma, and discrimination, combined with chronic under-resourcing, mean that prevention and treatment services for infectious diseases, mental health conditions, and substance use disorders are often inadequate in custodial settings. People in prison who inject drugs frequently face discrimination from healthcare providers, which discourage them from accessing health harm reduction services such as needle and syringe programs. Reducing stigma is essential to increasing service uptake, safeguarding health, and ensuring that these interventions reach those who need them most. Poor health outcomes during incarceration do not end at the prison gate. They continue to undermine the health of people with drug use disorders long after their release. These impacts also extend into the wider community, affecting families, straining health systems, and contributing to broader public health challenges, ultimately deepening existing health inequalities. The health of people in prison must be fully integrated into national public health strategies and should never be treated as a separate from the health of the general population. It is estimated that the prevalence of HIV and hepatitis B and C is between 2 and 10 times higher among people in prison than in the general population. Needle and syringe programs in prisons are essential for reducing HIV, viral hepatitis transmission. Yet, in many countries, these programs are undermined by the lack of enabling policy frameworks, lack of trained staff, and weak integration into prison health systems. It is estimated that between 56 to 90% of all people who inject drugs will experience incarceration at some point in their lives. This has resulted in many prison overcrowding with people who use drugs. These environments concentrate the risk, bringing together high levels of drug use, limited health care, and restricted access to evidence-based prevention measures. Some individuals may initiate injecting drug use while in prison as a way of coping with incarceration, trauma, or the conditions of confinement. UNODC works with member states and partners to promote evidence-based alternatives to incarceration for people who use drugs, recognizing that harm reduction, treatment, care, and community-based services are more effective options. These approaches help reduce prison overcrowding, improve health outcomes, and strengthen countries' compliance with the international human rights and drug control standards. The security nature of prison environments often restrict access to sterile injecting equipment. As a result, injecting equipment is frequently shared among multiple people, driven by the scarcity, fear of punishment, and the lack of harm reduction services. Needle and syringe programs offer a practical evidence-based approach by ensuring access to sterile injecting equipment. However, only 11 countries worldwide have implemented needle and syringe programs in at least one site, one prison. This level of coverage is clearly inadequate when measured against the global scale of injection drug use in the custodial settings. Effective implementation of needle and syringe program in prison requires policies that are both sustainable and equitable. Political commitment and comprehensive strategic framework are also essential to guide policy development that normalize harm reduction as a standard component of prison health care, ensuring it's delivered safely, consistently, and sustainably. Strong and meaningful collaboration with civil society organizations like communities and civil society organizations, they play a critical role in supporting peer educators and building trust with people in prison settings. If we are serious about ending HIV/AIDS, the needle and syringe programs in prison settings must be part of the solution. These programs are not radical. They are proven cost-effective and firmly grounded in public health and human rights. When we fail to act, we increase harm and deepen inequality. If we truly believe that prison health is public health, then our policies, funding decisions, and health systems must reflect this belief. The question before us is no longer whether NSP in prison work, but whether we are willing to implement them at the scale and with the commitment that public health demands. With this, I would like to thank you very much, and I wish we are successful event. Thank you.
Thanks, Ehab, for this very strong intervention and on the issue of prisons. This is addressed as well in the operational guide, and as we said, it's co-logoed and endorsed by UNODC and UNAIDS. Thanks a lot for joining. I think, Emma, we're 2 minutes over. We want to let people go. I think what I would say is I've seen in the Q&A, there's people from all over the world, from all of different settings. There has been amazing exchange and questions coming in. The speakers have been on time and fantastic. I think it's been very successful, highly attended, and we hope that this guide can be used and be helping people in the field to make programs a little bit better in this program area. Over to Emma, and thanks a lot for joining. All the best, and hope to talk soon to all of the people online. Thanks.
Thank you, Nicholas, and thank you for chairing us so beautifully, and thanks to all of our speakers and to WHO for their leadership. Just to say that we will follow up with a recording shortly. If anyone has any other questions that come up or issues that you want to see covered in a webinar such as this, please do let us know. Wishing you all a lovely day. Thanks, everyone. Bye.